My name is Simon Hook, radiographer at the Nuffield Orthopaedic Centre in Oxford. This presentation is designed to guide you in the use of the OSCAR device, which is the Oxford Stress System for Knee Arthroplasty Radiographs. It is licensed for the assessment of the pattern and severity of osteoarthritis within the medial and lateral compartments of the adult knee. It is designed for radiographers to use independently without requiring the clinician to be in the X-ray room manually stressing the patient. In this presentation, we will show how you, the radiographer, can gently apply a progressive force using the straps and pads to the patient lying on the X-ray table. Once positioned, the patient is X-rayed whilst experiencing a small force, which is compressing either the lateral or medial compartment of their knee whilst the radiograph is taken. The equipment is a modular system and can quickly be adapted to perform either a valgus stress view designed to identify OA of the lateral compartment or a varus stress view which can identify OA in the medial compartment. In patients for whom surgery is planned, knowledge of the pattern of arthritis assists with surgical decision making and helps the clinician determine if the patient is suitable for a total or unicompartmental knee replacement. The OSCAR device consists of the OSCAR knee wedge, two shaped foam blocks with coloured dots, intermediate cuboid and half blocks, a long grey knee strap, and two black ankle straps with red and blue coloured pads attached. Let's start with the valgus view. On a traditional AP standing image, it may be clear that this patient has reduced joint space in the medial compartment. However, this doesn't reveal whether this area has a healthy amount of cartilage. A valgus view compresses the lateral compartment in order to assess the cartilage and check for any reduction in the joint space on that side. It may be useful to note that the word valgus has an L in it, which serves as a reminder that when performing this view, we are compressing and assessing the lateral compartment. You can see when performing the valgus stress view, several blocks are used to keep the patient's feet apart while the long grey strap is used to pull their knees together. Hopefully you can see that this therefore compresses the lateral compartment as shown by the red arrows. Before the patient enters the room, it is wise to prepare the components. Generic to both valgus and varus views is the OSCAR knee wedge, which will sit behind the patient's knees once they are supine. Next, the long grey strap is needed. Looking at the word valgus at the top of the screen, the L and G act as an easy reminder that the long grey strap is the correct one required for a valgus view. This strap should be laid out inferior to the wedge. Next, prepare the row of foam blocks with the shaped blocks at each end as shown. All components have been designed so that any writing is orientated the correct way round for you, the radiographer, when standing at the foot of the bed. So you can see the word valgus is the correct way round and the grey dots are uppermost. These grey dots serve as a visual link to the grey strap and provide reassurance the blocks are the correct way round. In between go the intermediate blocks, one cube and one half cube. These are to ensure that there is sufficient room between the legs to stress the knees together. In slim or very short patients, fewer blocks can be used. Again, the L and G are helpful here to remind you to use lots of blocks, usually all of them, and that the grey dots should be uppermost. Remember, valgus should be the right way up for you standing at the foot of the X-ray table. The medial border of the patient's feet should rest against the shaped blocks and the ankles should be dorsiflexed. This is to prevent internal rotation of the leg on the application of stress. Ensure the patient's heels remain against the block, as the temptation may be for them to internally rotate, especially if they are in a bit of discomfort when the stress is applied. In my experience, most patients find it no worse than a little bit uncomfortable. The straps should be clipped together approximately 10 centimeters below the joint line. The strap is tightened until the white line of the force gauge sits within the green zone, indicating that an adequate force has been applied. To increase the amount of stress, the strap through the buckle will need to be slightly shortened. It is sometimes easier to unclip the buckle, adjust the strap slightly and then re-clip. Either way, the white line needs to be within the green zone of the force gauge. Of course, lengthening the strap will reduce the amount of stress. The beam should be angled 10 degrees cranially and centered on the knee joint. Prior to taking the radiograph, it's worth running through this checklist. Patella facing forward, long strap 10 centimeters distal to the joint line, force gauge in the green zone, heels tucked against the shaped pad, 10 degrees cranial tube angulation. It's worth mentioning here that although we are stressing both knees, we image them individually, even if stress views of both knees are requested. We can now assess our valgus stress radiograph. We shall assume the suitable force was being applied when the image was taken. The patella is reasonably central and entirely overlying the femur. However, the alignment relative to the lateral tibial plateau could be improved. Typically, we aim for less than 2 millimeters between the anterior and posterior margins of the plateau, and this can be corrected by increasing or decreasing the cranial angulation. In most patients, the standard 10 degrees works fine, but in very tall patients, the degree of cranial angulation may need to be decreased by a few degrees, and in a very short patient, the angulation increased to ensure we are shooting directly across the tibial plateau. In summary, the valgus stress view compresses and assesses the lateral compartment. It uses the long grey strap 10 centimeters below the joint line, lots of blocks between the ankles, the grey dots uppermost, and the word valgus should be correct for you standing at the foot of the bed. Use this checklist. You and your colleagues could pause this presentation and practice positioning each other for the valgus view before moving on to the varus view. For the varus stress view, we are compressing and assessing the medial compartment. I suggest you might remember this by thinking of the room between the knees. This could help you remember that the varus view is compressing and assessing the medial compartment. This time the shaped blocks are used to separate the knees, and the black straps pull the ankles together to create the varus stress to the medial compartments. Again, the patient will be supine with a generic Oscar wedge behind their knees. This time we will use the two black ankle straps with red and blue pads attached to them. The same shaped pads with grey dots are now turned around, so the word varus is now correct for you at the foot of the bed, and the red and blue dots face up to the ceiling. The red dots and red ankle pad are set up on the patient's right, the blue dots and blue ankle pad on the patient's left. The patient should lie supine with the back of their knees resting on the Oscar knee wedge. The shaped blocks should be placed slightly above the knee wedge against the distal half of their femora as shown. The half-size intermediate block is often used between the shaped blocks. This is done to provide adequate space between the ankles to apply stress. The loop on the ankle straps should be placed over the toes with the R for right against the medial malleolus. Again, this letter should be the correct orientation for you at the foot of the bed. The strap with pad should be passed behind the ankle such that the pad sits on the lateral malleolus for comfort. The left side should be applied in a similar manner. The loop over the toes, L the correct way up for you, sitting on the medial malleolus. Pass the strap behind the ankle so the pad rests on the lateral malleolus. The straps then clip together across the front of the patient. The ankles should be dorsiflexed and the patella facing forwards. This is to prevent external rotation of the leg on the application of stress. The length of the strap is then adjusted until the white line of the force gauge sits within the green zone, indicating that an adequate force has been applied. The beam should be angled 10 degrees cranially and centered on the knee. Prior to taking the radiograph, again, it's worth running through this checklist. Foam pads just superior to the knees with red and blue dots uppermost, patella facing forward, R and L on the respective medial malleoli, strap passing circumferentially behind the ankle as shown, coloured pads on the lateral malleoli, clipped together across the front as shown, force gauge in the green zone, 10 degrees cranial tube angulation. We shall assume the radiographer applied the stress so that the white line was in the green zone on the force gauge. The radiograph should be critically appraised to ensure that the rotation is appropriate with the patella central and the central beam is perpendicular to the tibial plateau in the compartment being imaged. The tube angle should be adjusted as with the valgus view, but don't forget we are now compressing and assessing the medial compartment, so the alignment of the anterior and posterior edge of the tibial plateau on this image is satisfactory. In summary, the varus stress radiograph compresses and assesses the medial compartment. Again, it is worth running through the checklist before exposing. On this radiograph, medial osteoarthritis is demonstrated. The lateral compartment, circled here, looks to be preserved. When the valgus view was performed, a reduction of the joint space is observed. This patient was not suitable for a unicompartmental knee replacement and went on to have a total knee replacement. This is another patient with medial OA, but this time their valgus view shows no reduction of joint space, and this patient went on to have a unicompartmental knee replacement. Finally, our referrers tend to specify varus or valgus. Some say stress views if they want both. Apply the stress gradually. I've never had a patient find it more than a little bit uncomfortable, but if the patient did find it difficult to tolerate, ultimately you can ask the referrer to come and stress them by hand. Obviously, in that scenario, the clinician would require lead gloves and lead protection. Thank you for listening to this presentation.